Relevant and insightful conversations about health and medicine happen here on MedStar Health DocTalk. The human body is really incredible when you consider the intricate network of nerves that send messages between the brain and spinal cord to muscles and organs. A signal from the brain to the heart, for example, tells it to pump blood without us even thinking about it. Or it might carry messages from the stomach to the brain to let us know it's empty, time to eat. Imagine if nerves carrying signals weren't functioning. The resulting medical conditions are wide-ranging. Neurologist Dr. Derrick Fox of MedStar Health in Baltimore is here to tell us more about a diagnostic test called electromyography, or EMG, that measures the health and function of muscles and nerves. I'm your host, Deborah Schindler. Thank you for being here, Dr. Fox.
Thank you for having me.
Communication between the brain and spinal cord and nerves and muscles depends on the health of the nerves. Can you give us a quick lesson or a little overview on nerves and peripheral nerves? What's the difference?
The nerves carry a very essential function for our body. I like to say that the nerves essentially act as wires or cables carrying electrical potentials communicated from the brain to the spinal cord, all the way down to the muscle or even the sensory receptors that allow you to feel and touch things.
It's always interesting to me to think about there being an electrical circuit in the body. That is hard for some people to understand. How do you explain that to your patients?
The best way to explain it is just knowing that our bodies are extremely complex and those signals are absolutely essential to every function that we can carry out, whether it's our walking, whether it's our balance, whether it's our sensation, whether it's our sight, our speech, our voice. All these different things rely on electricity and functioning of nerves and muscles. And they are very well connected to our brain, which acts as the processor, which initiates activity, but it has to be carried. And those nerve signals essentially act as the highways to allow those processes to be able to manifest.
So sometimes those highways develop potholes, they crumble, or whatever is going wrong. What can go wrong with the nerves that require a test?
Unfortunately, a lot can go wrong with the nerves. Sometimes the nerves, to some extent, can degenerate just with age, as many aspects of our body do. Other times, the nerves can be damaged just by systemic disease, such as diabetes, such as high cholesterol, such as metabolic disorders. Other times, there can be something like a vitamin deficiency that makes it hard for our nerve signals to be able to work. And in many other cases, there can be an autoimmune process where the body is attacked at the nerves, and that requires more aggressive treatment.
What do you mean by metabolic?
It essentially means for someone who, let's say, they have a long history of uncontrolled diabetes. Very often people with diabetes may develop nerve symptoms. And quite often it's the case where they're diagnosed with neuropathy around the same time that they're diagnosed with diabetes. So the function of the glucose and the glucose tolerance, unfortunately, does have toxic effects on the nerves.
What happens to the nerves?
The nerves over time, especially with those disorders, can start to become impaired. The nerve signals can travel slower. The nerve signals may not be as strong. The muscles can start to basically atrophy, or you lose the muscle bulk or the tone of your muscle. You can start to become weak. You can have balance issues. You can have tingling, numbness. You can even start to develop burning pain that makes it very uncomfortable to sleep at night. So there's many different manifestations of nerve dysfunction, but they can come from several different umbrellas. But metabolic disorders and diabetic disorders particularly are one of the most well-recognized causes of nerve dysfunction.
Is that damage from a metabolic issue reversible?
In many cases it is. There are some cases where if the nerve dysfunction has gone on for a very long time and you lose muscle, you can actually lose it to the point where it's difficult to get it back. So one of my major motivations in seeing patients with neuropathy or muscle disease is coming to an earlier time of diagnosis from the onset of the symptoms. So essentially that means the sooner that I see the patient, the sooner they can be treated and the best chance we can have of a good recovery or reversing the disease. Many times when the disease has gone on for many years, you can have some improvement once they're on the proper treatment, or we're correcting the toxic effect, whether it's diabetes or alcohol abuse or vitamin deficiency. But you have a better chance of full recovery from with an earlier diagnosis as opposed to a late diagnosis.
Yeah, the vitamin deficiency is an interesting component too. What vitamin would normally be deficient for there to be an impact on the nerves?
The most well-recognized ones are usually vitamin B12 and vitamin B1, but often vitamin B6 is found to be deficient in people with sensory neuropathies. Vitamin D is well recognized in many neurological disorders as well. However, the clear association of vitamin D with neuropathy is not that well established.
Tell us what neuropathy means.
Neuropathy is disease of the nerves. So when the nerves are not working as well, like I said, not traveling as fast, or the responses are not as strong as they should be, that manifests in weakness and in sensory loss, in tingling, numbness, even burning pain that makes it uncomfortable throughout the day. But most often, patients have difficulty sleeping at night because what we see is that in neuropathy, when your nerves aren't distracted by having to walk and carry your muscles around and carry your body around, and they're more in a state of being dormant or just basically being still, that's when the nerves really start to fire, and it can be uncomfortable to the point where it's difficult to sleep at night.
So when you said sensory neuropathy, that's when the nerves don't feel heat, sharpness, or at all?
Yeah.
You can't feel with your fingertips?
Yeah, sensory neuropathy is a little more specific to when there's nerve dysfunction only with sensory nerve fibers, because you have different types of nerve fibers. A lot of the nerve fibers will support muscle. So the more common type of neuropathy involves sensory nerves and supporting muscles. So patients will have not only tingling and numbness, but they can also have weakness. Whereas someone with a sensory neuropathy, they really don't have any problem with weakness. It's really only the sensory symptoms, the tingling, the numbness, the burning pain, the what we call paresthesias, which just basically means it's not necessarily tingling or numbness, but it's just an abnormal sensation that's not really well explained. Sensory symptoms, usually a lot of times we see in certain conditions. And like I said, one of them can be a vitamin deficiency, but sometimes we can see that in a connective tissue disease, such as rheumatoid arthritis or Sjogren's syndrome. So there are many different causes of nerve disease. I think far and away the most common, widely recognized cause is diabetes. But what I see is that there are so many different things that can cause nerve dysfunction. And with doing the test allows us to better understand the type of nerve disease you have, how far along the nerve disease has gone. It helps us to see how fast the responses are, how strong the responses are. And it can also give us some indication as to the timing of the disease, whether or not the disease is chronic or if it's relatively in its early stage.
Since we're going right to the test, let's talk about the test. A patient has some of the symptoms that you've described, maybe the sensory neuropathy or painful tingling. What else might be happening that would send them to a doctor?
That's a great question. One of the things that I've seen is many patients come because they keep falling. And it could be infrequent falls where they fall maybe just, once or twice in a month. But even when I talk further with them, they may tell me that, well, they have several episodes of near falls. They don't actually fall, but they get close to falling. So falls is a common complaint that, often I will see patients in this context for. Another one is balance disorder, where they just know they're out of balance. And one of the things that I try to do as a neurologist is understand, is this a balance disorder? Is this vertigo? Vertigo is a little different, where it feels like the room is spinning or you feel like you're really dizzy. But when I see patients in the context of a balance disorder relating from a neuropathy, it has really more to do with the patient not being able to feel their position in space, because you have certain nerve fibers that really allow for you to tell where you are. And it's something you don't have to think about when your nerve fibers are working just fine. But when you start to have issues with your nerve fibers and you start to have peripheral neuropathy, you can notice things as subtle as, well, when I go and I shower in the morning, I feel unsteady. And that could be just closing your eyes and all of a sudden you feel out of balance. You can notice that when you get up in the middle of the night, you feel unsteady. And in many cases, that's because we have several different inputs that allow us to maintain our balance. One of those things is our vision. Our vision is probably the most obvious one, because if you can see where you're going, it's easier to know where you're going, obviously. Another one is your equilibrium in your inner ear. That just basically means your balance in your head. So you need that also to maintain your balance. But the other one, like I said, really has to do with your nerves. And you really have nerves that help you to feel where you are in space. Even if you close your eyes and you hold your hand out, your hand can still tell exactly where it is in space. When those nerve fibers become extremely damaged, I've seen patients that develop even a shaking or a tremor because all of a sudden that sensory input is taken away and the hand starts to shake. So nerve fibers carry many important functions that often we neglect and we don't have to think about, but they become more obvious as they become damaged over time.
So someone who is coming to you with a balance issue has probably been to other doctors, ruled out sinus conditions or ear infections, right?
Yes.
Maybe they're at a geriatrician's office, and then the geriatrician or the primary care physician would refer the patient to you.
Yes.
And then you recommend an EMG.
Yes.
How do you test that when it's a balance issue? Describe for me how the EMG test is administered.
The EMG test is basically done with the patient on an exam table, and they're lying in a comfortable setting. I am able to attach several electrodes, which are basically these little adhesive pads that go on the skin or on the bulk of the muscle. And then I use a little probe that allows me to give a very light electrical stimulation. It probably most feels like a TENS unit. Many patients have had neck pain or back pain, and they use a TENS unit. So often patients are familiar with what that feels like.
It's a little vibration,
It's a light little electrical impulse.
but not painful.
It's slightly painful,
Oh,
but it's usually very well tolerated.
okay.
Sometimes patients have anxiety that's out of proportion to how painful it is. So very few patients that I've done the test on have had any issues with the test. So I think it's a very well tolerated test. It gives light electrical stimulation. And what that's doing is allowing the electrical signal to travel down the nerve to the muscle, or even just stimulating an area of the skin so that sensory receptor is able to pick it up and it travels up to where the electrode is, lying directly over the nerve. But either way, what that test does is it allows us to graph the nerve signal, the motor nerve fibers, the sensory nerve fibers, and it allows us to see how strong those responses are and how fast they travel. So it's a very good electrodiagnostic test, and it gives us very objective findings. Because sometimes you may see a patient and they may feel weak or they have a subjective complaint. And weakness sometimes, at least from a neuromuscular standpoint, is not all the same, because you can feel weakness from just feeling tired, from fatigue. You can feel weakness from being sick. But what I'm looking for as a neuromuscular neurologist is their frank weakness, like foot drop. They're not able to lift their foot back. Wrist drop. They're not able to lift their hand or extend their wrist. They're not able to spread their fingers apart. They lose muscle, and those muscles literally are rendered helpless. And it doesn't have to do with fatigue. It doesn't have to do with energy. It doesn't have to do with sickness. The muscle is literally damaged to the point where it has an inability at this point to move. So it's a very good test, and it allows us to kind of compare the clinical examination to the electrodiagnostic examination and better understand what's going on with the patient.
How quickly do you know that the nerves have failed or are not functioning properly? How quickly? Is that something that you have to read later and they learn a week later, or do you know right away?
I think it varies depending on the electromyographer, who is essentially the person that is performing the test. In some cases, it may take several days to really interpret the studies. Usually when I do the test, I'm able to go over the result with the patient right then and there, but that really depends on your comfort with interpreting the information. And the second part of the test is the needle part. We use a small, very tiny acupuncture-sized needle that goes directly into a targeted muscle. The first part that I was describing earlier is a nerve conduction study test, and it feels like minor electrical stimulation to see how strong the nerve responses are and how fast they travel. The second part of the test is the actual needle EMG. and the needle has the ability to be able to pick up on the electrical activity inside the muscle. For me, as an electromyographer, I can see the electrical activity on the computer screen, and I can also hear the electrical activity.
Oh,
and that
you could hear it.
Yes.
You're wearing a headset?
Not even wearing a headset, but I just have it on with the speakers in the room or with the computer audio. But the electrical activity in the muscle can make very distinct sounds.
What does that sound like?
It sounds funny to most patients. I don't know if there's a great way that I can describe it. It really depends on what you're listening to. Generally speaking, when I insert the needle directly inside a targeted muscle, I spend perhaps about less than a minute in each muscle. Like I said, it is usually very well tolerated. Most patients have absolutely no issue with it. But I essentially need to hear and see what the muscle looks like when the muscle is in a resting state, and then also see how the muscle looks when the muscle starts to give slight movement. And once I see that, I can combine that with the nerve conduction study tests and have a much better picture of what the neuromuscular condition is, whether it's a neuropathy, whether it's a muscle disorder, whether this is something more rare, such as motor neuron disease or ALS, or even muscular dystrophy. So it allows me to detect very simple conditions such as carpal tunnel syndrome to even more rare inherited disorders or acquired conditions such as ALS.
So let me understand something real quick. The muscle movement that you're measuring, is that something that you're creating with that acupuncture needle?
Yes.
Okay. It's not like the patient is on a treadmill and you...
No. It's very slight movement. It's really as simple as me inserting the muscle into one of the hand muscles and asking the patient to just spread their fingers apart. And with that small needle directly inside the muscle, with them spreading their fingers apart, the computer screen will show me all the electrical activity I need to see, and I can also hear it. So it's actually very informative. And a lot of times the needle EMG can help to put everything together even after the nerve conduction studies.
So sometimes you're doing that test and you automatically hear and see that it's very positive, or you automatically know that it's very negative?
I can see whether or not there is disease, for one. So really, it helps me see whether or not the muscle is normal. It also helps me to see if there is disease. Is there a disease from a muscle disorder, or is there disease from probably the easiest way for me to say it is a neurogenic disorder, which basically means it could be anything that includes neuropathy. It could include ALS. It could include a pinched nerve in the back or a pinched nerve in the neck. But it helps me to essentially classify what type of disease that we could be dealing with. And then it also helps me to target what area of the body is being affected. The other thing that it provides me a lot of insight for is it helps me see whether or not this is a disease that could potentially respond to treatment. And that's one of the reasons why I will do this test for patients with peripheral neuropathy, because quite often patients, they may think, well, I have neuropathy, but I've read that there's nothing you can do about it. And in many cases, there are things that you can do about it outside of some of the things that we discuss with trying to better manage the diabetes or better manage your overall health or try to supplement the vitamin deficiency that could be going on. But in some cases, we could provide a targeted treatment for an autoimmune disorder if the body is attacking itself at the nerve. And that can provide really astounding results where a patient can go from being wheelchair bound or having extreme difficulty with walking to being able to walk normally within a matter of several months. So it's a very worthwhile test, and it's a test that honestly, it can't be replicated. It can't be replaced by even a brain MRI or a spinal cord, because it's testing a different part of the body.
So you get that test back, and you said that you could get those abilities back. You could get the health back to the muscle. How does that happen?
Sometimes you can, but it really depends on whether we're dealing with a condition that can respond to that type of treatment.
Such as what?
Such as an inflammatory myopathy. It basically just means there's a muscle disorder that's coming from the muscles being inflamed. And an example of that would be a statin-induced myopathy, where someone may start on a medication for cholesterol, for example. And it's one of the reasons why sometimes patients have some hesitancy, because you can have some slight muscle aches after taking a cholesterol medication. But in very, very, very rare cases, sometimes patients can actually develop a muscle disorder. And often that's not even after taking that cholesterol medication. Sometimes they can have it even without prior use of a cholesterol medication. But it's most well recognized in someone that was previously on a cholesterol medication called a statin.
Once you discontinue the statin, then they are back to normal?
I wish it were that simple.
Can the nerves regenerate?
The nerves can regenerate. What our next step would be ordering some additional blood work and seeing if there are any antibodies that could once again suggest that this condition could be related to basically an inflammatory process. And once we see that, then we know we can try to start you on treatment. And the treatment could range from something as simple and as accessible as prednisone at low dose or at high dose, or it could be an infusion treatment. An infusion treatment where you would have to come into the hospital, or you would come into an infusion center, and you would have those infusion treatments. Sometimes they can be every month, sometimes they can be spread out every 2 months. But the idea is that after the infusion treatments, it's helping to calm down your body's immune system so that your body's immune system is not attacking your muscle or attacking even your nerves, such as can happen with even neuropathy conditions that are related to autoimmune processes.
And the infusion would be some kind of anti-inflammatory, or?
It would be usually IV immunoglobulin treatment. And IV immunoglobulin treatment is basically, in a way, it's giving your body new antibodies. It's probably a overly simple way of explaining it, but it's a way of giving your body new antibodies, because the antibodies that your body has, for some reason, is attacking your muscle or your nerve. So by, in some essence, displacing or kind of pushing out those old antibodies and getting a infusion of new antibodies, you can actually start to feel stronger. And when I see the patient on follow-up, I can notice that their strength is coming back. But sometimes those antibodies, over time, they will fade out, and you'll have to come back for continuing infusions. Sometimes we only have to do those infusions over several months. And in other cases, you may have to be on the infusion for a bit longer. So it really does depend on the case.
Are you actually discontinuing the statins for that patient if it's induced?
Oh, yes. In that case where there is a statin-induced muscle disorder or statin-induced myopathy, we would stop this statin.
But they were put on it for a reason. What happens then? They have to go back to the cardiologist?
They would have to go back to the cardiologist or go back to their primary care physician and see about an alternative method of lowering the cholesterol.
What's the most common reason people come to get an EMG test with you?
The most common reason is going to be tingling, numbness, balance issues, weakness, basically. It could be from back pain. It could be from neck pain. It could be from a known diabetic neuropathy. But often what will happen over time is that as the conditions worsen, the patient or even their referring physician or provider will become more concerned, and they will refer for an EMG testing just to see if there's maybe something more serious going on.
So in every case, though, even if it's a peripheral neuropathy, do you still give a nerve conduction test?
I will.
Okay. And clarify again what the difference is on those two, in the simplest explanation, so that non-clinicians like myself can understand.
For all intents and purposes, they are the same thing. Those terms very much are used kind of interchangeably, but when we say an EMG study, it really means an EMG and a nerve conduction study. It's very rare that you're going to have an EMG test without a nerve conduction study. So they basically go together. Generally speaking, if a patient is concerned enough about what they're coming in for, I will try to do the EMG nerve conduction study, because even if it ends up being completely normal, it can provide some reassurance to the patient. So that way we know, well, there's not a muscle disorder going on. Your muscles look strong. in some cases, it can find something maybe that we did not expect that, we're glad we found, because then we can actually hopefully target the condition and try to reverse any symptoms that they are dealing with so that they can have a better outcome. So I usually lean towards doing the tests just to be as well informed as possible about the state of my patient's nerves and muscles and how well they're functioning.
Give me an example of a scenario that might play out based on what you just described. If a test result comes back with information, that worst case scenario.
If that were the case, then I would talk with the patient at that time, and what I'll usually do is try to set them up for a follow-up visit in a short period of time. And I'll order some additional blood work just to make sure I'm certain of the diagnosis. And depending on the diagnosis, then we'll start on treatment, and we will try to get in contact with their referring provider to make sure that they're aware so that everyone's on the same page. In some cases, it's going to require some counseling because some of these conditions that I do see are very serious conditions. Probably the most well-recognized one is ALS, but there are other conditions that do require a lot of attention and concern, such as myasthenia gravis, because myasthenia gravis is another disorder that can actually cause you to have respiratory failure, and you can end up in the hospital for. So education and counseling, from my perspective, is one of the most important things that I can do as a clinician to help the patient understand their disease.
I've heard about the nerve conduction test because we have the hand center over at Union Memorial, and a lot of people who come in for carpal tunnel are asked to go get a nerve conduction test. Can you get that without the EMG? You said the EMG doesn't happen without a nerve conduction. Does the nerve conduction test happen without an EMG ever?
It's possible, but they usually do occur together. What will happen in that type of context will essentially be with the needle EMG, we're just targeting certain muscles. So I may only target one or two muscles, and that may literally be 1 minute of the needle testing. Whereas the nerve conduction study, that aspect of the test usually takes longer, perhaps 30 minutes, 40 minutes, and the needle EMG usually is only several minutes. But from my perspective, I base the nerve conduction study test and the needle EMG on what I'm looking for. If I'm looking for carpal tunnel syndrome, if I'm looking for a pinched nerve in the neck, which is called cervical radiculopathy, then I target the test in that manner. And in many ways, the test is algorithmic. I really don't know what I'm going to see until I actually do it. And once I start seeing some of the results, I may test other things. So I may look at other muscles, or I may test other nerves just to expand the overall picture and better understand what the condition is. So it does vary. The test can take as short as 20 minutes. It can take as long as an hour. It's usually in the range of about 40 minutes, I say on average. But most patients have no issues with the test, and they end up walking out feeling, in a sense, very satisfied, because it's one of the few tests, at least when I perform it, that since I'm able to go over the diagnosis and go over what the test shows, and they can actually see it, they feel like they walk away with some answers. And if I'm being honest, it's gratifying to me as well, and because I really enjoy seeing patients. I enjoy talking with them and understanding their history, what their motivations are, what their goals are. And when I understand the patient from that perspective, I can know how to treat them. I can know that, maybe their daughter is about to get married in 6 months and they want to be able to walk their daughter down the aisle. And based on those goals and those motivations, I think we can do a better job of helping them as opposed to treating the patient like they're a number. So I think what I try to do is give a very personal feel with all of my patients. And, obviously I want to reassure them, but at the same time, I try to be honest and I try to be forthcoming. I don't want them to be in the dark. I want them to know every step of the process. And, patients appreciate that. They appreciate someone who communicates with them and, provides a sense that they actually do care. So that's my goal as a clinician. And, I'm happy to do what I do, and I love seeing patients here.
Did you know that you wanted to be a neurologist when you were in medical school?
I did.
Yes, you went in knowing that. Interesting.
Yeah.
When did you know that you wanted to be a neurologist?
Well, I was in medical school, so I was probably in my third year when I rounded on patients with our attending physicians and the neurology residents. I was just so interested in the spectrum of neurological disorders, from people with Parkinson's disease to people with neuropathy, even people that had a stroke and maybe lost their ability to talk or to see or to walk. So just understanding how complex not only the brain is and the spinal cord, but, the nerves and the muscles are, they really allow us to do so many things that now, being a neurologist for as long as I've been a neurologist, I just have a really heightened appreciation for everything that we can do, and in some cases, patients, they really start to appreciate even small gains. So there are some times when I see patients for a serious disorder, and I'm not able to get them back to 100%. I'm not able to get them 100% back to their baseline. But I can get them to the point where they have improvement enough that they can appreciate. So even when I talk with patients and I communicate with them, it's my goal to also be realistic and in some ways manage the expectations. When you do that, they can appreciate even the small gains that they can make, from being in a wheelchair to being able to use a walker, and sometimes going from a walker to using a cane. So we really try to assess all the activities of daily living, because over time, when you make those small gains, they really are appreciated. They're respected even more.
Was there a particular case that intrigued you when you were making your rounds and you started to think more about neurology?
There were actually several. So I had an opportunity to do a postdoctoral fellowship after medical school, and I worked in the neurogenetics lab at the National Institute of Health. And I was seeing patients with a very rare neuromuscular condition called Kennedy's disease. And Kennedy's disease was basically a genetic condition. It's X-linked, so for the most part, it's only in men, and kind of presents like ALS, where there is very kind of slow progressive onset of weakness, of muscle loss, even fasciculations, which is basically twitching in the muscle. You can look at your forearm and you could see some muscle twitching, or in the hand. In some cases, those patients were misdiagnosed. They were thought to have ALS. And even in one or two cases, I remember seeing a patient that was diagnosed with ALS, and, they started making plans thinking that they wouldn't have long, only to find out later on that they don't have ALS, they have Kennedy's disease. The other name for Kennedy's disease is spinal and bulbar muscular atrophy. But Kennedy's disease, for the most part, there's not really a great treatment for it, but you'll develop slow weakness over time. It's not as ominous as ALS. So, for the most part, you'll have a relatively normal lifespans. But those are some of the cases that really, even after I kind of knew that I wanted to be a neurologist, really geared me more towards neuromuscular disorders. Neurology is a very complex field, and neuromuscular disorders is probably even more complex because of the spectrum of disorders that we see. I see cases as simple as carpal tunnel syndrome or a pinched nerve in the back, and I see cases that are also very rare, genetic disorders. But it's something that excites me, and if you're curious about how the body works, and if you're curious about our ability to function, and you're curious about diseases, it's definitely an interesting field. But sometimes seeing a neuromuscular neurologist can take a while. So one of the things that we're trying to do is provide great access to care here in the Baltimore region. We're really making it a point to build our neuroscience center here at Franklin Square. And we have several great neurologists. We have great physician assistants. We have great nurse practitioners. So I've been really impressed with my time here.
I have to ask about that peripheral neuropathy. What do you do if the tests come back horrible?
It really depends on the degree of the peripheral neuropathy. In some cases, peripheral neuropathy, the treatment is really more, we like to say, supportive, which basically means there's not really a medication to treat it, other than making sure you have the equipment that you need. If you need to use a rolling walker, if you need to go to physical therapy, a lot of times I do refer patients to physical therapy, especially if I'm concerned about them falling, making sure they have the home set up in a way so that they're less likely to fall, having a ramp, having handrails in the bathroom. In physical therapy, they can come and perform a home safety evaluation. Other times I will start a patient on a neuropathic pain medication. And for me, that really depends on how severe the neuropathy is. And that's only because I don't want a patient to be in pain where it's difficult for them to sleep at night. So in those cases, I will start the patient on a neuropathic pain medication, such as gabapentin or such as Lyrica, to make it so that they're at least comfortable and it can take away from that pain and they're able to sleep well and not be stressed or up all night. In some cases, there are more targeted treatments. And that's one of my major motivations for wanting to do the EMG test, because I really do want to see if there's a targeted treatment that I can start you on for the neuropathy. I'd like to start that as soon as possible. I have seen cases where patients, they have a diabetic neuropathy, and, I'm sure the diabetes is playing a role in it, but there can also be an autoimmune process as well. The thing that makes me think about an autoimmune process for someone with peripheral neuropathy is someone who is progressing rather fast as far as the disease. I don't mean they're having difficulty walking over 30 years with neuropathy. I mean someone who really just started developing symptoms a year ago, and now it's difficult for them to walk. That is a little fast, and that would heighten my suspicion for maybe some underlying process that could be going on outside of diabetes.
So it sounds like sometimes there's a lot of other tests required to pinpoint a diagnosis, but you can rule out things with the EMG.
Absolutely.
Right.
Yeah, and there are many other tests that go along with the workup for neuropathy. The core of the test that I will usually order will be vitamin levels, essentially. A lot of times I may, if I have some suspicion for a connective tissue disorder such as rheumatoid arthritis, I'll order tests in that regard as well. I will look for tests to assess how well the thyroid is working, since that can also cause nerve issues. And if I have some concern for an autoimmune process, I will order targeted antibody tests as well.
Wow, there's a lot that can be done.
There are many things that contribute to disease of the nerves. So understanding your body, understanding how the nerves work. The nerves, I like to say they really do reflect the health of the overall body. And one of the things that I always talk with my patients about is the importance of physical activity. One of the most common questions I get for patients with neuropathy is, will I be able to walk? They're concerned that in 5 years, they're not going to be able to walk. Mm-hmm. They're not going to be able to move around as much. And I try to really emphasize that physical movement, just because that physical activity really helps with the increased circulation in the legs. That increased circulation is so important for the nerves. If you have very good blood flow that's surrounding the nerves, then your nerves are going to be able to be healthy and work well. But if you don't, it's going to make it harder for the nerves to be able to function. The other aspect of it is, if there's a lot of leg swelling, the leg swelling can basically push on the nerves, and it's going to be able to hard for those cables or those nerves to be able to function when there's a lot of excess fluid that's pushing on the nerves. So I really, even though I am a neurologist, obviously, but I really try to focus on overall health conditions in a way. And I try to provide counseling where, even if there's not a particular treatment that I can start the patient on, I will talk with them about maybe lifestyle changes that I feel can be beneficial for their overall health, that once again is going to be reflected by the nerves, and that will help the nerves to be able to work better.
And mitigate the symptoms.
Absolutely.
Have a better quality of life.
Yes. Making these lifestyle changes will help the patient with their activities of daily living, walking around better, moving better, having better balance, not having as much tingling numbness, hopefully not having as much pain, being stronger. We all want to be stronger. So all of these things, when you are able to address what's causing issues with the nerves, your body will be rewarded with all these benefits: increased strength, increased balance, better sensation, and just overall mobility, being able to move around better. So there's just many benefits when you target trying to make sure your nerves are working in an optimal state and working the very best that they absolutely can.
If there's just one thing that you want listeners to take away from this conversation, one message, one point about EMGs, what is it?
An EMG test is really one of the most important, if not the most important test that you can have on your nerve and your muscles. If you have suspicion that you feel you are weaker than what you should be, if you have suspicion that you have some tingling numbness, if you have some suspicion for a balance problem, if you have some underlying suspicion that your body just isn't working as well as you need to, I think it's really good, and I urge you to strongly consider having an EMG test. It can really provide a lot of information as to how well your body is working and how well your nerves and muscles are working. And it can help us to catch things a lot earlier as opposed to them going undetected. Because as clinicians, it's generally harder to treat conditions once they've gone on for a longer period of time. And it's usually a lot easier to treat conditions when you catch things early.
It's so satisfying to talk to a physician who's really passionate about what he does, and that's really clear in talking with you.
I appreciate the opportunity.
We've been talking with Dr. Derrick Fox at MedStar Franklin Square Medical Center in Baltimore. Thank you for sharing your expertise with us here on DocTalk. For an evaluation with Dr. Fox, call 443-777-7320 or visit medstarhealth.org/Fox.